Hi, it's Dr. Ann Metz, and this is The Psychedelic Skeptic, where we believe that nothing is the cure for everything. If it's your first time here, I'm a licensed therapist, counseling professor, and in fact, a psychedelic therapist. But I'm also a skeptic when it comes to some of the claims around psychedelic medicine. And that's what I'm here to explore. Today on the show, living with HPPD.
I would urge people with HPPD to simply listen to what their heart actually tells them, is that you can develop a certain intellectual, spiritual apparatus for telling yourself why these symptoms are actually okay and why you don't mind them or why you even enjoy them. Because for some people, that simply isn't the case. And it took me a number of years to realize that actually I hate it, as I mentioned. But I didn't feel that I had the psychological or spiritual maturity to admit to myself that I was constantly experiencing something I hated.
This is part 2 of my series on hallucinogen persisting perception disorder, or HPPD. Again, this episode contains challenging content that may not be appropriate for everyone, so please use your judgment in listening. Today, we're continuing our conversation with Ed Prideaux. Ed Prideaux completed a master's degree in psychology at the University of East London in 2023. He previously led operations part-time at the Perceptual Restoration Foundation, an HPPD harm reduction and research nonprofit. He's written for publications like the BBC, FT, Vice, The Guardian, The New Statesman, and others. And I actually found out about Ed's work through the Challenging Experiences project that is happening right now and is spearheaded by Jules Evans. In this episode, we'll explain some unexpected aspects of HPPD, including positive responses to the condition. We'll also discuss the potential increase in HPPD cases as psychedelics become mainstream, and what clinicians should know about diagnosing and treating HPPD. Join us as we continue our conversation and our explanation of this complex and often overlooked aspect of psychedelic use. I begin my conversation with Ed by asking him if anyone has ever responded positively to HPPD.
So in my master's research, kind of the central finding was that there is a cognitive behavioral element that when one is adapted to these symptoms, you can live with them, if not enjoy them. And that's speaking very simplistically. And I can obviously add all sorts of nuances about how some people aren't able to adapt to them, and it's not right for them to adapt to them. It's okay, people hate them. Even within my own survey, let alone the conversations I had outside of it, there are a number of people that identified their recovery consisting partly in developing a spiritual reinterpretation of their symptoms. They viewed this as some kind of spontaneous shamanic style phenomenon, an energetic occult phenomenon. And I remember having a very interesting conversation with someone who knew of a group of individuals with HPPD and a related condition known as Visual Snow Syndrome, whose symptoms can present very similarly to HPPD, who would engage with their visions, specifically the visual snow, the static, sort of grayish, filmish particles in the air. They would specifically engage with their visuals with visualization meditation and then manipulate them through the force of intention as a kind of magical practice, as it were, such that they would become and morph into anthropomorphic entities with whom they could have occult relationships. And as someone who's simply curious about different kinds of phenomena people can experience, even on a psychological level, that's obviously very interesting. But I also covered in my Mad in America piece a number of people who enjoyed their HPPD. One person I remember would look out the window at the clouds and watch them transform before his eyes and found great aesthetic appreciation in that phenomenon. I included the testimony of a guy who, in seeing the constant movement of the material around him, had a sense of the illusion of stability and concreteness in the material world, that really it's constantly moving. Is it Heraclitus or Parmenides who had the sense that everything's always moving? One of them. I suppose you could have an ancient Greek reframing of your HPPD symptoms. But again, I would urge people with HPPD to simply listen to what their heart actually tells them, is that you can develop a certain intellectual, spiritual apparatus for telling yourself why these symptoms are actually okay and why you don't mind them or why you even enjoy them. Because for some people, that simply isn't the case. And it took me a number of years to realize that actually I hate it, as I mentioned. But I didn't feel that I had the psychological or spiritual maturity to admit to myself that I was constantly experiencing something I hated. Because it's an upsetting realization. You can deal with it through an attempt at, I don't care. I'm just going to focus on my own mindset. Or you can do a mindfulness thing of I'm not going to judge it, good or bad. Or you can do a neurodiversity approach and go, it's just somewhere on the spectrum of the variety of human perception, and it's neither good nor bad. But those things just weren't true for me. They didn't actually capture who I felt. And I found some healing in accepting that I hate it. And frankly, in accepting that my catastrophic fear, which is a common one, which is that I have some kind of brain damage, is true. And to the extent that we can anxiously and fearfully resist this idea that people with HPPD may be interpreted as having brain damage, that only reifies this idea that brain damage is something abnormal and something to be othered. Things exist in the world. Some people do actually have brain damage. Taking large quantities of powerful chemicals in a way that alter your visual apparatus in ways you don't like, and that cause clear optical illusion, like double vision. This quite plausibly is a form of brain damage. And I feel comfortable accepting this fact. My vision being maladaptively bright, it is a form of optical damage. And I think that taking that seriously is a way of communicating just the seriousness of HPPD. You have to accept a certain degree of tragedy. And it motivates the kind of decisions that might help you to recover when you accept that you actually don't like it.
Could you say more about that idea of having to accept the tragic?
Basically, especially as a Brit, we struggle with things that are just bad. Brits can often default to giving advice as to why it's actually not bad. We can default into humor and irony, and that's something that I did for years, and it's kind of so I continue to do around HPPD. It's all just a laugh. I've got this thing, isn't it funny? Isn't it hilarious? Or you can simply, you got to ride the wave of negative emotion. That something bad has probably happened and that one might have a regret in life. I think it's a broader cultural pathology we have of the whole no regrets mentality, that basically wherever you are in life is either where you're meant to be, or even if there's no cosmic principle that has brought you to this moment, that basically it's all fine because you are where you are, live in the moment. Well, actually, what if you did make a mistake in life? What if you aren't where you should have been? And this was the way that I was understanding it at the time I had this realization. At that time, I was developing a form of faith in a kind of higher power, a higher power that I still have a very complicated relationship with, so as it were. But I felt the only way in which I could have the freedom to move and accept what my heart was telling me, which is that I hated it, and I did have regrets, and that this sucks, was through accepting that I had made various errors in life, that I had abused drugs, that I'd had an addictive relationship with LSD and cannabis at university in a way where I acted impulsively and endangered my future viability as a member of society and a family member and a human being through risking the aggravation of a neurological disorder and perhaps nascent mental illnesses through impulsive hedonism. And these are unpleasant things to accept, but I felt the freedom to accept these things insofar as I had a relationship with a higher power that had the capacity to forgive me through truly exposing the wound in all its tragic rawness, as it were. So that's maybe part of a piece of what the Challenging Experiences Project has been studying. That is these like worldview shifts, changes in metaphysical or religious or spiritual beliefs that can assist people's recovery from post-psychedelic problems. But the trouble is that metaphysical beliefs are necessarily relative and quite shaky. And so hasn't been the most consistent source of consolation for me, sense of a higher power, because who knows really? I don't think anyone knows if God exists.
I just am so moved by your honesty and how open you've been with this and sharing a bit about what's helped you recover, and I think that there's a lack of training in our field about how we're taught about adverse experiences and how we're supposed to approach them when our client has one. And I'll just give you the example that kind of comes to mind is that anytime a client has something difficult that comes up, whether it's a sense of depersonalization, if it's something really traumatic. The line that we're all supposed to deliver is the idea that, it's your inner healing wisdom showing you what you need to see. I think on some level, there might be some meat to that theory, but I also feel like it's really problematic when we're talking about something like HPPD. Where's the intuitive, intelligent wisdom in that?
Yeah. Especially because it has this distinctly neurological flavor that can trigger people's worst terrors about psychedelic drugs. So something that I experienced and a lot of people experienced. I had an email just this morning from a guy saying that my blog on the topic had saved him, for lack of a better word. It was a blog about the catastrophic terror that HPPD is schizophrenia, especially through famous case studies like Sid Barrett or Brian Wilson of the Beach Boys, who's just gone into a conservatorship, actually, after his wife died, long-standing mental health issue dating back to his LSD use in the 1960s, as well as other problems. This meme of the acid casualty was, I think, obviously enormously influential throughout much of the 20th century, which then coalesced with the quite simplistic biogenetics sort of trigger theory of schizophrenia that psychiatry had for a long time, where it collapsed a lot of the psychosocial, subtle associations and causes of schizophrenia into just, you have some kind of genetic vulnerability, which is very difficult to detect, then just trigger it. And so you end up like these basket cases, as it were. And so when you start experiencing visual distortions, you quite reasonably associate that with seeing things, with schizophrenia. Not least if you go to a professional who doesn't know what HPPD is, just hears, okay, 17-year-old boy took LSD and feels like a robot, he says, feels dead. So clearly displaying some kind of thought disorder mixed with dissociation. It's become very isolated because of some kind of anxiety about people thinking he's a freak. So obviously he's got some kind of social isolation going on, and also sees things. Okay, this seems like schizophrenia. And this is something that would happen. People would be misdiagnosed with psychosis spectrum disorders and schizophrenia. And I remember talking to a guy called David Kozin, who is a kind of long-standing veteran member of the HPPD community. And he was involved in starting HPPD online back in the 1990s, I think. And he would regularly speak to people who had developed HPPD and coach them on how to broach the issue with their psychiatrist to access the relevant medication or psychotherapy. And he would always say, never say the word hallucination, because they might think you've got schizophrenia. So HPPD has this distinctly neurological flavor, which then activates some of our worst catastrophic fears around psychedelics and mental illness, especially schizophrenia, and that makes it hard to talk about. But really, I do think that there are interesting things to draw out maybe, which is to consider this kind of situations in which the catastrophic fears are activated, the particular kinds of catastrophic fears you have, and then perhaps to connect those to tendencies you had before you even developed HPPD. So it's quite interesting that a colleague of mine, who's a humanistic hypnotherapist, had a client with HPPD, and within 2 sessions, his issues, which he considered all to be about HPPD, were obviously so general and so connected to his psychological background that HPPD wasn't even mentioned past session 2. And it can be the case that long-standing psychological trends are simply activated and made present through the stimulus of this new HPPD thing you've got. But also, I think there are specific advices that therapists could share. And this is what seems to be the case from various case reports that I've sort of summarized in my thesis, and some of the evidence I gathered in my thesis, which is that you can take a CBT approach, of classic CBT approach, of identifying the catastrophic thought, challenging them, encouraging a retraining of attention, encouraging an attitude and an ethic of acceptance. And so acceptance and commitment therapy might show a particular affinity for HPPD, as well as the non-judgmental awareness of mindfulness. But also, I would say that it's very difficult to deal with HPPD, secondly, because some people can misdiagnose themselves. Because some of the symptoms of HPPD are actually it's become vaguer over time. If you look at the descriptions from the 1970s when HPPD was first being codified as a psychiatric disorder, the descriptions were fairly striking. And there's even pictures on Dr. Henry Abraham's website. He was the originator of the diagnosis, which he shares drawings patients made from all throughout the mid to late 20th century of patients describing their HPPD symptoms. It's striking stuff. It's obviously something changed. Whereas now, through the internet, through online communities, it's become a bit vaguer. Floaters is one thing that I've found a bit of a bugbear. Floaters, that is, you look at the sky or you kind of allow your vision to lose focus and you see those squiggly lines. People can be convinced that the floaters are a sign of HPPD. People can be convinced that seeing any static is a sign of HPPD. Whereas actually it's very normal at night to see a bit of static. Very normal to look at a bare surface and see, oh, okay, it's a little bit static. But you just notice these things more after you take psychedelics and you're smacked in the face with 12 hours of the most aberrant visual phenomena you've ever experienced. And in a way where you're precisely training yourself in a kind of gripping mode of perception where you stare at surfaces for extended periods of time. Whenever in your life would you have took the care to stare at the carpet for as many as 2 hours? You simply haven't done that before. And so people can maybe, in the acute period after taking psychedelics, find themselves spacing out more on their surfaces. And then they notice, oh my God, that just moved. And they look it up and they find HPPD. And then people can catastrophize, congregate in these online communities where basically every post is, my life's over, what's happening? Is this a symptom? So basically with HPPD, what am I getting at here is that I'm concerned about the possibility that people can be misdiagnosing themselves and then seeking official diagnoses with clinicians that don't necessarily know the difference between a false and a veridical diagnosis. And then it gets stamped. You've got HPPD when people actually never did.
It sounds like a clarity around the duration after an experience is a really important piece of the diagnostic process that's not really accounted for in the DSM.
Yes, exactly. I often saw one case report of a guy who was diagnosed with HPPD after a 25-year refractory period, which is, it's possible with my sort of groove theory I share. It just took the right trigger for him to be re-experiencing his LSD visions, but I'm skeptical, frankly, of a course-century refractory period.
I would be encouraging him to go get an MRI if that happened, because I think something like a organic brain tumor might be a better explanation for something like that after 25 years. Yeah. Okay, so we have this expansion of people who potentially are self-diagnosing or clinicians that might be diagnosing HPPD. But I'm also curious, do you think we'll see an uptake in cases as psychedelics become legalized?
It's hard for me to say, really. Because if you had asked me 5 years ago, with all these trials going on, would I have expected there to be more HPPD cases already? Yeah, probably. If this is primarily a neurophysiological phenomenon, maybe. But it's through doing these trials and seeing that there are some edge cases that have arisen that maybe we could talk about, that they don't meet. It's not being a cut and dry, we gave someone psilocybin, now they've got HPPD now. That doesn't happen. But that could be because of the particular kinds of people that have been included in these trials, especially because in the TRD trials, many of them, would have done SSRIs before. This is a hypothesis that was shared by Matthew Baggett, who authored the 2011 survey I mentioned earlier, about 1 in 25 people maybe having HPPD. He speculated that people in the TRD trials might have done SSRIs before, and SSRIs are also associated with triggering visual perceptual disorders. So it's possible that to the extent that they took SSRIs and then didn't develop something like an HPPD phenomenon, which I believe at least some universities and trial administrators do ask about. They ask you, do you experience X, Y, Z? They haven't, then they're the clean population that weren't going to get HPPD anyway. They don't have the biogenetic vulnerability, maybe. That's one post hoc explanation. But whether more people will get HPPD than where it's legalized, I haven't checked the data, but is it even the case that psychedelic use has necessarily gone up that profoundly?
I mean, it's always hard to get accurate data on something that's illegal. I mean, people just tend to not want to write that down. So I'm not even sure that we could say that for sure. That seems like it's going up. Anecdotally, it certainly seems like more people I know are taking psychedelics
Yeah.
than they were 20 years ago, or certainly when I was in college. So
Yeah. Perhaps maybe even if more people aren't taking psychedelics, then it's that the mainstreaming and the legitimation and the destigmatization of psychedelics means people, albeit variant portion of the population that were doing psychedelics, now feel more encouraged to seek help. But is the risk that in that help seeking, the professional doesn't know better and we lack really firm diagnostic criteria? They get diagnosed even when they possibly shouldn't be. That's a concern. But I also feel encouraged by the fact that because HPPD is a very niche issue, the people that have developed expertise in it really do know their stuff. So two individuals that I found immensely beneficial to talk to, and I always redirect people to, are Tomislav Majic, who is a German psychiatrist based at it translates to the psychedelic ambulance clinic at the Charité hospital in Berlin. And he deals people with a range of, it's a specialist outpatient clinic, people with post-psychedelic issues. And he has a profound expertise in HPPD on a clinical level. And the other guy's Gerard Alderliste, who works at another outpatient drug-specific clinic in Amsterdam. And these guys, as long as we just continue to defer to their wisdom and their experience, because they know about these issues with hypochondria and full self-diagnosis. So I feel encouraged. And also people kind of figure out for themselves if they're getting too obsessed with HPPD. People can go through a phase of obsession on the Reddit page and then just log off because they realize that actually it's harming them to continue to be obsessed. And I do wonder if the kind of people that continue to be obsessed are of a particular hypochondriac, neurotic, OCD temperament, that I worry that even without HPPD, they would have been experiencing mental health problems anyway.
Well, I would say that for somebody who's, that if we were to really look at how that behavior is functioning and the self-diagnosis, I would imagine that at the core of it is just a desire for their pain to be legitimized in the world.
Yeah.
And I think that culturally, if we did a better job of acknowledging what people are really going through, the kind of need for diagnostic criteria or a label would feel less pressing.
Yeah, I would agree. And there does seem to be a broader opening to perceptual disorders, maybe. I just remember that New York Times piece, which talked about people who had been diagnosed with psychosis, spectrum disorders, and schizophrenia, and have learnt to live without the label, and have learnt to live without stigma that it can carry. And that piece did attract a lot of controversy. But maybe in time, there will be a broader trajectory toward just a less judgmentalism.
Yeah. You have brain damage.
Yeah.
Yeah. I would love to ask you what else you think you wish clinicians knew about HPPD. I teach a diagnosis class, so you have a captive audience on the other end of this podcast of people who will one day be in a position to diagnose things as either HPPD or not.
Well, my own personal experience with psychotherapists is very peculiar to me because I've only seen 3, and 2 of them weren't very good. Actually, all of them weren't very.
That's a great place to start.
One issue is, I think that there has been, so to just I was going to make a point that would have been completely unnecessary, but I think that in the psychedelic space, as they call it, there can maybe be this bias where because something involved being caused by psychedelics, therefore we need psychedelic specialist clinicians to deal with it. We need people from the psychedelic community who are, quote, psychedelic informed. Maybe people who have their own personal experience with this. I'm actually skeptical of this because if only because HPPD behaves very similarly to other somatic symptom disorders in many ways, where I would feel completely fine with someone with HPPD to go and see a specialist who had never even heard of it. As long as they're not judgmental, as long as they're a good person who's a good listener, I think it's okay if you've never even heard of HPPD, and maybe it's actually a good thing. Because, for one thing, I think that the psychedelic therapy community, and this is something that I discovered myself, has its fair share of people who think they know what's what. who have a certain inclination towards gurudom or subtly attempting to control people, which is quite worrying. This is something that was noted in a really good essay called The Psychedelic State by, it was called Henry Fisher. And he said that even from his most casual conversations with people in the psychedelic community, when talking deep, when kind of comparing notes on trips, he would always notice this subtle way in which his other people would try and control him and control what they thought was the bet, was they thought he should have been thinking, what they thought he should have been listening to, what they thought he should have been realizing. And I noticed this with my therapist, who was a rather neat, passive-aggressive individual who decided to tell me that my reluctance to take psychedelics again was me internalizing the logic of the free market.
Oh, wow.
It was my internalized neoliberalism. That was why I might not want to take psychedelics again. And obviously that was quite upsetting. And because he had a certain bias in favor of psychedelics, especially because people in the psychedelic world can maybe have a bit of a seed mentality. If I mentioned HPPD, he would sometimes mess up the acronym. He didn't really express much interest in understanding why it's unpleasant. He seemed quite keen to shuttle along the conversation to why it's actually okay and why I might enjoy it. So I wouldn't necessarily get too hung up on this issue of a psychedelic specialism. Maybe this sounds awfully naive from someone who hasn't actually had much diagnostic experience, but any diagnostic experience, but he hasn't done that much specific research on the issue of diagnosis or how the clinic works. And I have my psychology masters, but all that said, I'm kind of drawn to just a quite humanist approach to psychotherapy in which people are simply listened to and their phenomenology is taken seriously, and that's enough. That I don't think it's that necessary for there to be. I think it's good that diagnosticians and clinicians know what HPPD is, but if only to manage the risk of undue stigma and the sort of subtle judgment and stigmas and dehumanizations that can occur from confusion and skewed eyebrows and furrowed brows and intimations that the other person's crazy. It's good that they just know what HPPD is and this is the thing. But then once you've accepted that, then just get into the real business of, okay, what is this person actually telling me? What is the actual meat and potatoes of what they're experiencing? How is that connecting to their life in the past and now and in the future? I think that's, for me, that seems necessary and sufficient.
Oh, interesting. Yeah. I have a couple of quick, short questions. Is there any evidence that certain drugs are more likely to induce HPPD?
There has long been a tentative hypothesis that LSD is most associated with HPPD. In my survey, LSD and then the LSD cannabis combination came out as the most frequent trigger of HPPD. But one interesting study was done by Fran Vollenweider and colleague in January 2022. It was published, I believe it was called On Flashback Phenomena, in various drug trial coming out of a lab in Switzerland involving MDMA, psilocybin, and LSD, pure LSD. Okay, and that's a critical point, that there was no meaningful difference between the different drugs. If that hypothesis is true, we might expect 15% of the LSD cohort experienced these transient flashback phenomena. It's the psilocybin and the MDMA were less, but actually, if I recall, psilocybin was actually by some single percentage point actually the most likely to provoke it. Whereas for a while there was this like unchallenged assumption that psilocybin doesn't cause it. It's something I even saw in being promulgated by an expert on the condition, John Halpern, in an interview once, and by a very influential YouTuber called psychedelicsThe, who said that psilocybin can't cause HPPD. And so I would speculate that maybe street LSD is more likely to cause HPPD if it is because of LSD's massive adulteration problem. I talked about this in an article for the Ecstatic Integration Substack, which is I don't think people know just how often LSD might be being adulterated. There was some striking data out of Brazil, which indicated, I believe, that unfortunately, I've forgotten the exact percentage increases, but it was something like between 2014 and 2019, there was an enormous increase in the percentage of LSD tabs seized by Brazil police that had adulterants on it. 25I NBME, sort of synthetic mescaline, even fentanyl. There was a sort of hyperinflation across the EU and across the US of novel psychoactive substances. And I don't think it's necessarily a coincidence that 3/4 of the central team at the PRF developed HPPD from 1P LSD, including me.
Wow.
One of the people I tripped with when I was at school, there were 3 of us, and 2 of us walked out with lasting visual symptoms, and this was 1P LSD. So I speculate that if there's anything, it's going to be the synthetics, maybe. But then different drugs can cause different kinds of phenomena. Like the DMT has a particular association with reactivation, which seems like which is obviously a very different phenomenon to persistent visual condition. That
How about ketamine? Is it associated with ketamine at all?
Yes.
Okay.
Yeah, ketamine, and I'm trying to think of the other dissociative that came up in my study. Forgotten. But there was another dissociative that came up as a trigger, as well as delirium, like DXM was the other dissociative. Deliriums like Datura and DPH also came up. In fact, I think that DXM has been profoundly underrated as a trigger of HPPD. I've barely heard it talked about.
I've never heard of it before.
DXM.
DXM, no.
Dextromethorphan. It's used to be better known under the name Robitussin.
Okay. All right. That makes
syrup.
more sense now.
It was
just needed the capitalist brand name, and I got it.
And people would, it was called robo-tripping.
Robo-tripping. All right. Yeah, I think that was popular when I was a young person. Great. Well, that was super helpful. And thank you so much. At some point, I would love to talk to you again because I feel like I didn't even get through half the questions I had. So maybe we
Yeah, that'd be fun.
Thank you. The Psychedelic Skeptic was created by me, Dr. Ann Metz, with production help this week from Jesse Duke and Andrew Merriweather. Our podcast music is by Wes Swing. The Psychedelic Skeptic is available on your favorite podcast app, and you can learn more about me at annmetz.com, or you can follow me on Instagram at Dr. Metz. If you want to recommend the guests for the show or ask a question about psychedelic therapy, feel free to send me a note at hello@annmetz.com. I'll see you next time.